Okay, so we finished looking at anatomy and kind of the skeleton, joint, ligamentous, muscle attachment, origin, insertions, and stuff. But I want to look at things a little bit more functionally. And what we talked about with muscle action, the adductors adducting and the abductors abducting. I kind of want you to throw that out the window for a while. Okay, throw it out the window forever, because it's really not how things work functionally. So today we're going to talk a little bit about how things work functionally. And I want you to kind of open your minds a little bit to say, oh, okay. Because we have to keep in mind that the joint works off of 3 axes. It's a multi-axial joint. It's a multi-planar joint. So whenever that joint moves through its range, the axis changes. And when the axis changes, the line of pull or the force vector for that muscle changes, and it may change to a different side of the action, or a different side of the axis, creating a different action for the muscle. So when we talk about the adductors adducting, well, it may be that that's not what their primary focus is. It may be that their primary focus is more along the lines of restraining hip extension, or controlling hip extension, or loading the hip in extension as it prepares to move into flexion during gait. So let's look at the hip during a couple of different functional movements, and one of those functional movements is bending over to pick something up. So we always learn never to pick anything up from your back, but that's actually a strategy that some people employ, and some people do fine with it. So I'm going to pick up my 5-pound weight here. I'm going to do it 3 different ways, and we're going to kind of examine each one of those methods. So here we are, and I'm bending. I'm standing in front of my weight, and we're going to do this from the side so that you can see what my hips are doing here. And here's my greater trochanter, so we can kind of work off of that as an axis. And I'm going to just bend forward, and I'm going to pick up my weight. And I'm going to keep my knees straight, and I'm going to come back up and lift that weight back up. Okay, so I'm going to bring the weight back down, drop it off, come back up. So that motion occurred primarily in the sagittal plane, right? We didn't have any real rotation occurring. We didn't have any real side-to-side motions occurring. We primarily had motion in the frontal plane, or motion in the sagittal plane. Everything else was stable. It's a good example of the concept of pelvifemoral motion. For me to get my hands down, I run out of room at my hips. So then my pelvis continues in an anterior tilt, anterior direction, and then my lumbar spine continues to flex. Now, if I use that strategy to lift up everything that I want to lift, is that going to be a good strategy? Is that going to be an effective strategy to lift a heavier weight than 5 pounds? Especially if I have some tone issues, or some tightness in my hamstrings, or some tightness in my thoracolumbar fascia, or some tightness in my rectus spinae. Probably not. That's probably not going to be an effective method to bend forward and pick something up. So the other way that we may look at picking something up is this idea of a sagittal, of a squat lift. And this is one that we're probably more familiar with. So I'm going to come over my 5-pound weight. Now I'm going to get nice and squared up over my 5-pound weight, so that when I squat down to pick it up, I'm going to keep it nice and close to my center of gravity. So I'm going to reach down and keep my back nice and straight, and I'm going to lift this up. Okay? I'm going to drop it back down, come back up. So boy, am I using my glutes and my quads. One more time, I'm going to reach down, keep that back nice and straight, lifting it back up, keeping it close to my line of gravity. So as I drop it back down, let's talk about that for a second. Is that how we typically lift? And in many cases, yes. Is that the most functional way to lift? We'll decide after we're done today. That is a good example, though, of a nice base of support lift. I'm using multiple segments, maintaining a better length tension relationship of my glutes and my hamstrings to allow that squat to occur to allow that forward flexion to occur. Again, it's primarily in one plane of motion though, right? We're only moving in one direction. What happens when I'm walking down the street, oh, there's a 20, and I turn around and I do what? Boom, I pick it back up. I pick that $20 up because I want to snatch it before somebody else does. So there is an example of a motion that is now triplanar. That is probably a more normal method of lifting. Go and watch your garbage guys picking up the trash. They're going to reach, boom, throw it in. Reach, throw it in. Is this what we would consider to be an ideal method of lifting? Well, some people say, well, gosh, no. Look at all that torque that's occurring across the back. I mean, it's craziness. But the reality is, as long as my linkages are adequately loaded, I can grab what I'm lifting and explode, and that force goes through all the segments correctly, and I can lift with greater loads, greater force, than if I'm just lifting something straight ahead, which is not nearly as functional. Now, why is this going to appear to be more functional than lifting something straight ahead? Let's look back and remember, what's the orientation? Let's look at just the glute maximus for a second. What's the orientation of those fibers in the glute maximus? Are they purely up and down? Are they purely side to side? No, they're angled. They angle down, right? Remember how they angle down, attached to the gluteal line and the IT band? That angle, that directional force creates a rotary component. So my challenge to you is that when we look at lifting, are we lifting with rotation? Is lifting a transverse plane activity? Let's look at all of the muscles that are responsible for lifting, and let's examine, is there a transverse plane component to the fibers? And I will say, without one, they all have a transverse plane component. So we should really be looking at this type of a motion, or this type of a motion, when we're lifting. So let's keep that in mind. Why then might somebody get hurt doing this? Same way that somebody might get hurt doing this. If they don't have range of motion through all the linkages, or they don't have strength through all the linkages, and they create a compensatory movement pattern that creates a load that exceeds the demands that the tissue can handle. Does that make sense? Exceeds the demands that the tissue can handle if the linkages are not coordinated. Comes back to that proprioceptive component. Remember, are we getting all of the proprioceptors, the muscle spindles and the Golgi tendon organs we talked about in Module 1? Are those firing? Are those adequately working? So that's kind of how we can apply that architecture of the hip and in a functional movement pattern. And what I want you to think about as you continue to read through the chapter is how those muscles are laid out, what's their orientation, and what are they going to do when your foot's attached to the ground and you're going to bend over and pick something up, or you're going to reach back and jump. Okay, what do we do first? Boy, we load, our feet are straddled. Rarely are we going to jump off of 2 feet. A lot of times we're just jumping off of 1. So we want to make sure that we understand the linkage that's occurring. Second part of what I want to talk about today was what happens when we look at compressive forces that are going to the joint. So when I'm standing by a kind of bilateral stance, mathematically we could calculate that to be about 1/3 of the weight of your body would go through each joint. But the reality is, when we look at things scientifically, when we look at things in a lab, it's closer to 80 to 100% of your body weight goes through both hip joints. So each one individually is is taking on a much greater compressive load. We kind of say, well, okay, that doesn't make any sense. Why do you think that's occurring? And the reality is probably that there's some muscle contraction occurring. There's, just to maintain your upright position, your psoas and your iliopsoas and or psoas major and iliacus are probably firing to kind of maintain that stability. So that's going to create compressive load. That extended position is going to wind the Y ligament of Bigelow. It's going to wind the iliofemoral ligament up, provide additional compressive forces. So those are the reasons, just in standing, that we're probably getting compressive loads that are exceeding just the weight of the body. So what happens when I stand on one foot? So when I start standing on one foot, I'm going to have significantly greater load because now I have to add the weight of my hanging leg. So I have to add the weight of my hanging leg to the formula for the compression. And the other component that I now really have to add is to maintain my level pelvis. I have to add in the force of the hip abductors. So abductors are maintaining my pelvis in a level position. Part of that is creating a rotary component. Part of that is creating a compressive moment. So compression from the abductors is also going to increase that load. So we may see a significant increase in joint compression loads on unilateral stance. Again, weight of the body, weight of the force of the ligaments, force of the abductors contracting and controlling that, maintaining that position. But what happens when pain or weakness inhibits or exceeds the ability for the load on that joint? And that's when we start to see compensatory changes. Most commonly, when somebody has a weak hip or they have pain in their hip, we're going to see a lean. So when they take a step, I'm going to move back here a little bit. They take a step, they're going to lean to the side. What is that doing? That's taking my load, it's taking my center of gravity, moving it over, decreasing the moment arm associated with the weight of my body. Smaller moment arm means I have less of a counteracting load that the abductors have to generate. Okay? So that's one compensation that we'll see. Another compensation that we'll see is that foot will hit the ground or that hip will drop out. So we get a kind of a contralateral pelvic drop. Okay, so that hip drops out. So I'm either going to lean or my hip's going to drop. When I have them both, kind of looks like a gait pattern that we call the Trendelenburg pattern. Trendelenburg gait pattern. How can we correct it? Well, one way to correct it is to use a cane. So if I'm on my right side and I keep the cane in my right hand, each time I put my cane down with a step, I can decrease the load by about 15%. Probably not as nearly as effective. In fact, when we look at mathematically, we look at how much forward lean we get. We actually can decrease the compressive loads much greater with forward lean than we can with a cane in this ipsilateral side. The effective side for the cane then becomes the contralateral side. So I take a step, and now I have a moment arm from my foot to the cane. I have a moment arm from my center of mass to the cane. I have a moment arm from the joint to my lats because my lats are pressing down. So I have now a moment arm from the attachment of my lats over to the hip, creating a counter-rotational torque to keep that pelvis level. When I add those up, I can decrease the compressive loads on the hip by a significant amount. So when I have hip pain and I want to decrease the load, compressive loads on a hip, a cane in the opposite hand is going to be your most effective compensation or your most effective treatment in decreasing those loads. So just to summarize real quickly then, we have a lot of different motions that we can address. We have a lot of different things that we can do. Keep in mind the really significant triplanar structure and this triplanar motions, the triplanar stability that occurs in the hip. And all the things that we do revolve around that multi-axial, multiplanar, dynamic, stabilizing structures within the hip. Okay? So we'll go on, we'll move on to hip dysfunctions and look at hip types of injuries in our next lecture. Thanks.